Hi there, my name is Gerard Green. I'm a pelvic health physiotherapist from Birmingham in the UK, and it gives me great pleasure this morning, so we're here at the start of June, to speak with Dr. Judith Thompson from Perth in Australia. So Judith, first of all, I'd like to say many thanks for giving up your time, which I really appreciate, and all the people listening will really appreciate. And just to, most people will know who Judith is. So Judith does many things. So she is a clinician, first off. She works in her Body Logic clinic in Perth, where she works within pelvic health physiotherapy. She's also heavily involved in the master's program in pelvic health in Curtin University in Western Australia. And she is also heavily involved in research in pelvic health, where she has a PhD in really looking at the use of ultrasound imaging in pelvic health. And she's a fellow of the Australian College of Physiotherapy. She is teaches extensively. And I think she's one of these really inspiring people who we all look to. And it's really great that I've had the opportunity, mainly thanks to COVID-19, to speak with Judith. So Judith, a really big thank you for agreeing to speak to us.
Oh, thanks, Gerard. That's a great wrap to start off with. But yes, I'm passionate in lots of areas, and pelvic health has taken me on a big journey through teaching and research as well, but my first love is in the clinic and with the patients.
And I think Judith, I think when people look at your the academic work you do in Curtin, and the research and publications you do, I think people will probably be pleasantly surprised that you still work clinically. And I suppose my first question is why is that clinical work still so important to you?
Well, I think I just love that connection with the patients. I've loved physiotherapy. I've been passionate about it. I've loved every day from the moment I qualified. And I think you learn so much from your patients. And it's clinical questions that have got me into researching, basically. And so the research came second, the clinic came first, and the research and the teaching came after. I've always loved teaching other physios, being mentor to junior physios in different parts of my career. I spent 10 years doing spinal cord injuries and worked at Stoke Mandeville and over in New Zealand, and ended up in Australia at the spinal unit here, and then got into pelvic health when I had my children, and was very interested in the ante and postnatal preparation, and then started learning more about the pelvic floor, and found my love, and started doing, at that time we had a graduate diploma in continence and women's health running at Curtin at that time. That course actually did finish, but a group of us went through at that time, and we've really been a strong clinical group that have moved through together. So yeah.
And what is a typical day in your private practice like for you? So what patients are you seeing?
So because I think now I see more of the complex clients, I do still see lovely, anti-postnatal ladies coming through. I've, some of the ladies that I saw back when they had their babies still, you care for them all through their life. So you see them through the menopause and those times. But pelvic pain is my passion and my love, and so I tend to attract more pelvic pain patients, and because my wait list is a little bit longer, then it tends to be that those people that are willing to wait to get in to see me often are the more complicated patients. But our clinic, we see everything. men, women, children, and I have a couple of the physios that are more specialised in pediatrics, and some of the girls just love seeing the male prostatectomy, but basically I would see anything pelvic health.
And I think, Judith, I think those of us who are involved in pelvic health physiotherapy, we have people who've inspired us. And, you know, I was very fortunate to work with Dr. Ruth Jones in Southampton, and she kind of taught me and mentored me, and she has inspired me. So I suppose who kind of in the early days, who inspired you to really get involved and do more and, you know, do your research and do your PhD?
Well, in pelvic health, it was probably Patricia Newman, Ruth Sapsford, Sue Markwell were the main physios when I was starting. But as far as my PhD, Peter O'Sullivan and I have worked together many years. So I worked with Peter in New Zealand, and then he moved to Perth and I moved to Perth the same year. And that was to do his master's at Curtin. And at that time, I was just living here, and we ended up seeing each other over the years. And then he was actually doing a research project looking at people with persistent pelvic girdle pain.
Okay, yeah.
And they were looking at the biomechanics of the diaphragm and using real-time ultrasound to look at the diaphragm. And he said, oh, I wonder what's happening at the other end of the cylinder, and went, oh gosh, you can see the bladder, and phoned me up and said, Judith, I'm seeing the bladder and the pelvic floor. Do you want to come and talk me through this? And so I went like, oh my God, you can see it, and you can, and everything, you know, we're doing the active straight leg raise test and different functional movements, and we could see the impact of that whole core cylinder and monitor it. And so that got me interested in the ultrasound. And so Peter has been a great mentor, and him and Patricia Newman were my supervisors for my PhD. And so I've had Pete's pain science and cognitive functional therapy at the same time. Trish works very closely with Lorimer Mosley and David Butler, and at that same time, right. Paul Hodges was doing a lot of his sort of core research.
That's quite a strong peer group.
I know. And then Margaret Sherburn in Melbourne started using the transabdominal ultrasound, and her papers were about the same time as mine. And so we had this great group of think tank of minds working to be curious. It was really, once I'd had a look at the ultrasound, I was actually working at a maternity hospital, and they had an ultrasound machine, and I asked the doctor, is it okay if I use the ultrasound machine? She said, oh yeah, we only need it on antenatal clinic, but any other time just come in and use it. And I started looking at patients with that transabdominal ultrasound, and people just got that light bulb moment. Oh, my pelvic floor. Oh, and it moves. Oh, wow.
And I think from my perspective, I feel quite passionate that ultrasound, and a lot of this is based on your work and obviously Ruth's work and Joe Millius's work. I do feel that ultrasound is a real game changer in pelvic health, because I think it allows people, especially maybe to start doing transabdominal ultrasound, it allows them to visualize that ultrasound, visualize that pelvic floor, and it's almost that they can, you know, look at what's happening inside, but stay outside. They can look at it functionally, and I think it's also almost a safer way for maybe some of the musculoskeletal physios, some of the sports physios to start to get involved in pelvic health physiotherapy, because they can start to look at that pelvic floor without initially then having to do either vaginal or rectal assessment. So I think your work is almost kind of shaped that easier route for people, I suppose people like me, into pelvic health physiotherapy. So I've recently, probably in the last year or so, become quite friendly with Suzanne Carney, who's one of your graduates, who's now back in Ireland. I think she misses all the sunshine in Perth.
Oh, she was great.
Yeah, Suzanne was one of these inspiring people also. And I find it really fascinating that, I work in Coventry University and we've got a brilliant MSc in musculoskeletal physio. And in the UK and in most other countries, there are loads of musculoskeletal masters. There are loads of sports physio masters. But I think in Curtin is one of the only pelvic health masters anywhere. So we've got the brilliant course in Bradford. There's the course that you mentioned in Melbourne. But there aren't many. So I suppose my question is to you, do you, bit like Suzanne, do you have many international students on the course in Curtin?
So we do. We've had people from, particularly from New Zealand, from all over Australia. So half our graduates are from elsewhere. So we have 52% that are WA based and the rest are from elsewhere. So we've had people from Japan, Malaysia, Singapore, and Canada. Actually, we've had someone from. She was someone that had lived in Perth before. I mean, it is quite a commitment to come and live here, because if you're doing it as an international student, it is more costly.
Yeah.
And so a lot of people come and do that full time as a full-time 1-year course.
And I think also it's mainly from speaking to Suzanne. It's brilliant that it looks like there is pediatric pelvic health covered.
Yes. Yeah.
And male pelvic health.
Yeah.
And obviously from your interest, lots of female and male pelvic pain. So why do you think it's really important that we really get more people involved in pediatric pelvic health, male pelvic? Why is that so important to you and your team in Curtin?
Well, pediatric, we definitely have a big need, because a lot of the habits that happen as children then go on to form what happens later in life. So doing the pediatric units, you go, oh my gosh, yeah, that's the development of the bladder. We all need to start back there. And toileting habits, constipation. All these things are really understanding the pediatric side of things really sets a really great thing. And they've shown research into people in waiting rooms at urogyne clinics, when they look more likely to have had recurrent UTIs or things like that as children, and some history. So the younger we can get people doing good toileting habits, the better. And
it may be different. It may be different in Australia, but I know here in the UK, finding a pelvic health physiotherapist who is specialised in pediatrics is less than easy. So we definitely need more people. We definitely need more people seeing the kind of children, adolescents. And I think, kind of following on from that, I think myself personally, I look quite enviously at Australia, where you've got lots of people heavily involved in male pelvic health. So you've got your group in Curtin, you've got the Paul Hodges and Ryan Sapsford group on the East Coast. Then you've got Jo Milius, who's also in Perth on her prostatectomy work. You've got the Martians, Peter Jordan, Stuart Baptiste, Craig Allen. But that's quite unusual, because you don't have that concentration in other countries. So why do you think Australia or Australian physiotherapy has kind of grasped that male pelvic health and really ran with it, when you don't see that in other countries?
Yeah, I don't know. It's unusual. I mean, and Sian Morrison's the other person that she's doing quite a lot in Melbourne. And I think she was actually one of the first people to be doing male pelvic pain. So she really developed a lot of her clinic. She was seeing more men way before any of us, I think, in the pelvic pain area. But most of those other men, like Stuart, I think he got interested in the ultrasound, but Peter Dornan came much more from a MUS point of view. A lot of them either knew someone or had a dad that had a prostate problem or something that got them interested into it. And then, yeah, and Paul, I've been chatting to Paul for many years, as I say, and we travelled together over to the States to run an ultrasound course over there. And he got really interested in the pelvic floor and understanding that. And then with Ryan, just took off on the male, doing just absolutely excellent studies that we've just learned so much from. And that's when I really switched from doing my transabdominal to transperineal, was based on Paul and Ryan's work.
And so you've had multiple publications. And obviously in Curtin, it's, I suppose the good thing about being involved in teaching and a master's is that you always have loads of really keen, motivated, brilliant students. So what research are you currently involved in that you can tell us about?
Well, we're in a really, so pelvic pain, so I've done a lot with the ultrasound over time. And then we, at Curtin, for your final research units, you have to do a project that completes in a year, which really limits us to the scope of the project. So we have done quite a lot of the smaller audits and those sort of things, looking at something that's manageable in that shorter time. But we're now doing a series of publications really looking into the psychosocial screening of people with pelvic pain. So Trish Newman and myself, actually we were inspired by Jonathan Hill, coming from England with the Start Back short screening form. And he came over to Perth and obviously had quite a lot to do with Peter O'Sullivan. And so our whole clinic did his course. And I really liked his short screening form, but the words didn't fit with my patients. So Trish Newman and I developed our pelvic health one that we just made up. But it served us very well over the years for screening much more for those psychosocial factors. So we decided that actually we'd like to do this officially. And because we'd just plucked the questions based on the Start Back, we actually went back to do what's called an e-Delphi process, which is actually consulting experts on what should be in a psychosocial screening questionnaire. So that was when I came over last year and met Gilly Bond and Carolyn Van Dyken because I was recruiting them for my expert panel, along with Peter O'Sullivan, Helen Slater, and then some doctors and a whole group of psychologists that work in the area of pelvic pain. And so we came up with a 15-question 3PSQ, the psychological screening questionnaire. And this year, we're trying to validate that so that we can make that more publicly available. We're just checking to see that those questions do actually match with the longer questionnaires, so that as pelvic health physios, we could have one form that we screen for a lot of domains. So stress, anxiety, depression, catastrophizing, fear, health anxiety, sexual trauma, sexual assertiveness. And on your first, if you do that first up, it really helps your conversation with your patient. To understand that straight away. And we're also designing, I don't know if you've heard of the free back pain screening questionnaire that was developed in Fremantle here in Western Australia by Ben Wand, who looking at sensory motor perception. And I was thinking of that when I was listening to your talk with Adrian Wakestaff on hard flaccid. It's that altered perception of your genitals and the pelvic area. We're actually, with Gilly and Carolyn, looking at doing a similar process through a Delphi study, adapting it for the perineal area and the genital area.
Yeah, I'll have to.
So that you can screen.
Free back. I will have to look.
Yeah,
at that.
so look up the free back, which is definitely so how people feel that their back is asymmetrical and out of sorts, and we see very similar things in the genitals, that they feel enlarged or shrunken or asymmetrical, or and that altered smudging in the motor cortex. Then looking at some of Julie's work of how, when we find that, how can we program that?
And so so that is fascinating. So you've got several really quite really big impactful projects going on, which is
so that, yeah, those are, I've got a few other little ones, but I won't.
I have a feeling you've got more than that as well. I think it's safe to say, Jude, that without COVID-19 has really wiped out a lot of physiotherapy clinics in the UK. It's been quite a tough time for a lot of people. But I think I suppose a positive of COVID-19 is that people have really got comfortable and at ease with the technology we're using, like Zoom. And I think it's safe to say that if it wasn't for COVID-19, I wouldn't have the opportunity to speak to you. And so I know in my university in Coventry, we moved quite swiftly to online learning. And in terms of postgraduate courses, I've been teaching a lot. So what's happened in Curtin? What shift has happened in Curtin because of COVID-19?
So yeah, we had to massively change very quickly to do all our units online, obviously, at the moment. The thing with pelvic health, though, is that we have to still assess that ability to do the vaginal and rectal assessments and their hands-on skills that you need. So we will be having to do some catch-up classes once everything opens up, but we've done as much as we can of putting lectures online, and we've been chatting together how it'll be exciting to have the likes of you actually talking on the course to open up different opportunities to talk to experts throughout the world, where we've just been using our Australian lecturers. We can now think big and actually open up things. But we've done a lot of like collaborate learning, where all the students can discuss, and we're just about to start our telehealth clinics because we normally have an in-clinic where students come to Perth. We actually, with them in the clinic with a patient, we mentor them for 2 clinical units, so that we're giving them that feedback immediately with a patient. So we're starting, so as not to delay people that want to finish this year, doing telehealth clinics this week.
Brilliant.
So
amazing.
Yeah, so we will have 2 students and myself and a patient that has volunteered, and we'll be doing the interview and everything online. And then the student has to form a problem list, come up with a management plan, and do the education. And I'm there to mentor them and give them feedback.
I think so. What I've been doing in my clinic is that, so myself and some of my other male and female pelvic health physios, so we've been seeing lots of patients on Zoom. And I suppose that is true, that once the patient consents, it's quite easy to drop a third person
in there
into that Zoom appointment. That's
and so that opens up so many exciting possibilities. That, you know, if somebody, I mean, here we have such a big state that if somebody's living in Broome, which is like, you know, 2 days drive away, you know, I can have the physio in Broome and myself and the patient have a consult together, and they can do the vaginal exam while I'm there, and talk. I can talk them through what the plan could be to move forward. I mean, this opens up so many opportunities.
And I suppose Australia must be suited to that, because, you know, it's a big country. And outside the cities, presumably the provision of pelvic health physiotherapy can't be in some of those small towns.
And in fact, one of my little published papers, it was only a very small case series, but we did that one year as looking at, for rural patients with stress incontinence, how effective was it? And the majority, there were 2 that needed to be referred on, but out of the 10 people we did, 8 did really well. So, it just means that it opens opportunities. But I think this mentoring role is really could be wonderful, Gerard, because just imagine if you can then hop in and help someone while the patient's there.
Yeah, that is because I know the university is looking at different ways of supporting more so our undergrad. But that's kind of made me think now. You've made me think now.
Well, that's always the aim.
You're very. I suppose Australia has kind of led the way on name change within physiotherapy, in that to bring in the male pelvic health physiotherapy. So we've had name change in terms of New Zealand, Australia, the American associations has changed, and you've also had you've had a male graduate from Curtin, which I find inspiring. Yeah. So how can we get more male physios involved, Judith? How can we do this? And I think it is happening. It is happening.
It is happening. I think you're doing it. That's the question. I need to go the other way back to you, because I think you've done more for it. What male physios need to see is more male physios doing this. Because, I mean, we have male gynecologists. There's no reason why male physios, and actually a lot of the men want to talk to a man about those things, because again, if you've got erectile dysfunction or problems, I can't fully understand that. And I think it's really inspiring, the work you're doing, and it's nice to see Jane Chalmers' student Tom Astor.
Yes, Tom's brilliant. Yeah, brilliant.
Brilliant. Just got into it as an honours project before he'd even started physio, and so you don't have to have a whole years of experience to come into this field. I think this, and we definitely at Curtin are looking to develop more of that men's health area. We've always had it as part of our unit, but we haven't had options for men to choose that as a stream. And that's having had wonderful Laz with us, he's really helped us. He did everything that the girls did, and but he's also told us his needs, and we're basing our future planning around that, of actually working specifically to get more men in this area, because we definitely need them, and the men would be delighted to have more male physios.
And I think also, I think what's also important is to really get more musculoskeletal. You see a lot of pelvic pain,
yeah.
and we know that pelvic pain has a musculoskeletal component, pelvic health component,
yeah.
in science education. But I think also it's important to draw in those musculoskeletal physios,
absolutely,
sports physios who have got quite specialist skills, to get them involved also, which is slowly happening, which is
but
good.
When I see you teaching a class with with predominantly men in there, you're making those changes, and it's only a question of time now.
But I will have to say this. I think I have been very fortunate to work with Ruth, and Ruth was a musculoskeletal physiotherapist. She did a lot of the kind of back in the 90s, a lot of the kind of motor control stuff. So I think Ruth was always keen to get musculoskeletal physios in. And then I'm quite blessed, I think, to have Jo Milius as a close friend. And I think Jo, because her background is musculoskeletal sports, I think she has always kind of pushed to get male physios involved, musculoskeletal physios, women's health physios, basically get as many people as you can to get involved. Now we've also because I was speaking to you, because we had planned to speak, I also put a call out on social media for some questions. Now there is good news and bad news. The good news is we have tons of questions. The bad news is we probably won't get them all. So I think what I'll give you some of them, and I think because we've had such an interest, I think what it would be wonderful to do at a further date, Judith, is maybe do a specific chat around the ultrasound, because I think we could speak a long time on that. So I think we'll probably do a separate one on the ultrasound. But some of the questions is you probably get asked this all the time, really, is what's your preference, really, doing transabdominal ultrasound or transperineal?
I love transabdominal as that introduction to your pelvic floor. The first day I see someone, to just show them straight away, this is the pelvic floor, let's get you to do a contraction, let's get you to do a relaxation, and actually see what happens. That functional element, particularly with the men with post-prostatectomy, most of their leakage is on movement, so you can do some great functional stuff. And I think I will never give up transabdominal ultrasound. I've had lots of discussions with Trish Newman about this, who is so passionate about transperineal that she feels that that's the only way. But I feel that that transabdominal, it's a lovely first introduction.
I agree. Yeah, definitely.
But if I've got a man that is leaking and I want that much more focused anterior action, then the transperineal is a really great way to go. If you're doing research, you have to be doing transperineal. Transabdominal is just not accurate enough person to person. But it's just wonderful in the clinic every day. It's my bread and butter. I love it.
Brilliant. And I think technically it's much easier to teach people to do transabdominal. And then I think the way I look at it is that once people get happy, confident in transabdominal, then the next stage is to teach them transperineal, because the transperineal is complex.
Yeah, you need more time. You need somebody to mentor you. You need to know what you're looking at. But actually, never be frightened of it, because it's actually easier than you think sometimes when once you've got your placement right and stuff. When we do it with the students, they go, oh, actually this isn't as bad as I thought it was going to be. So don't be afraid of doing that. But as I say, as your first appointment, when somebody's nervous, it's lovely to keep your knickers on and just have a look at your pelvic floor.
Something you may be interested in, Judith, that last year we were pitching is the wrong word, but we were pitching really. We were kind of pitching for some pelvic health work for one of the UK sporting bodies, and when I went to some of those meetings with some of the elite sports visits, I kind of made a real emphasis that we would look at they were kind of young female gymnasts, and I made a real big thing that we would look at them through transabdominal ultrasound. They were used to having ultrasound for maybe shoulders and knees. So we pictured that we would do a very musculoskeletal type look at the pelvic floor using transabdominal ultrasound, and that really they really bought into that, because those gymnasts were used to having ultrasound. They were used to being assessed in terms of movement, and I think the ultrasound it felt very safe.
Okay, yeah, and I agree. The criticisms I had to deal a lot with this in the early stages when I was passionate about the transabdominal ultrasound, is that you can misinterpret what you're seeing. If once you have skill, you can pick up so much on transabdominal, but you can think somebody's got a poor pelvic floor and actually it's an overactive pelvic floor and it's not moving. And so again, it's open to mistakes. And I think that a lot of people were very wary that actually we were getting some false people being told, oh, you've got a very weak pelvic floor, but actually it was perhaps
and
overactive.
I suppose we might need to save this for the second podcast, but I suppose when people like yourself or other people are using ultrasound, we're not doing it in isolation. We spent 45 minutes.
We've got the history, and we can go on and do a vaginal or rectal exam to confirm what we're seeing. But if we're just using it in a sports clinic, sometimes I was getting people sent to me that, oh, I've been told my pelvic floor is really weak or whatever, but they just hadn't assessed it properly.
Yeah.
So that's a caution that transabdominal doesn't tell us everything. It should be done in conjunction with that full assessment, and obviously hands-on assessment where able.
Brilliant. And I suppose another question, this question is kind of from me really, is that, so you've obviously seen a lot of change within pelvic health physiotherapy. Where do you see pelvic health physiotherapy going? What's
I'm very excited. In Australia, it's the fastest growing specialist group.
right?
So, you know, musculoskeletal
Yeah,
sports, and then we've got, but they're sort of staying fairly similar. We're increasing. So I think we've got the, you know, some of the best evidence base
exactly.
for incontinence, prolapse, and now the area of pelvic pain and endometriosis is getting so much more funding. And, you know, that's a chronic condition that can be well managed with physiotherapy program.
And the post-prostatectomy, that
the post-prostatectomy, you
started to
know,
hear a lot about that. Even in the kind of public domain, we're hearing more about the role of physiotherapy post-prostatectomy.
and if you look at the big study going on in the States of the MAP studies looking into urogenital chronic pelvic pain and the physio side of that they're looking into. And this will now become, you know, recommended management. And for so many years, it's just been treated by antibiotics and it's all in your head. And actually, no, we've got a really good program that we can help you. So I just see us going from strength to strength. And, you know, I feel really excited that with the number of graduates we have with more knowledge than, you know, the Susans going around the world, and we've got you spreading the word, and, you know, the more people we've got talking in this area. And I think, yeah, the podcasts, Laurie Fauna, Marika Hart, Anthony Lowe, you know, there's a lot of talk around.
Yeah, and there's a lot of, I suppose there's probably a lot more sharing of knowledge and sharing of those it's probably easier to connect with those
yeah. And what I've always found in pelvic health is people, you know, that collaboration and wanting to share knowledge. It's been amazing in Australia. We've, you know, luckily there was a few of us all doing our PhD at the same time, but it sort of created a really great collaborative environment, which has been amazing to be part of. So strength to strength, that's my answer, Gerard.
Brilliant, yeah, brilliant. Yeah, no, I'm very passionate, and I do think it's an inspiring area of physiotherapy to be involved in. Now,
it's how we let the public know what we do is the area that we need all the social media savvy people to be doing better, because even the word pelvic health doesn't mean a lot to people.
It means very little, I think.
So, and we've struggled so much with the name, as you say, women's, men's and pelvic health, you know, women's health and continence, pelvic health and continence, you know, all these different versions. And then you're thinking you don't want to be gender. At Curtin, we're very non-gender, so they don't want us to call it men's and women's thing because it's gender binary. So what do we call it?
Yeah, and I think we have an advantage here in the UK in that we are allowed to openly advertise. We're allowed to use patient testimonials. I think one thing I think we're less restricted
than we are. Yeah.
Physiotherapists are still not brilliant at promoting what they do to the public, especially in terms of pelvic health, where they can really change people's lives, quality of life, relationships, family life. I think one thing that I found really useful, although I don't think you're allowed to do it in Australia, although you can correct me if I'm wrong, is that what we've done in the clinic is we've had patients write blogs for us. So it may be a woman who's had a really bad prolapse, a female pelvic pain patient, a post-prostatectomy patient, male pelvic pain. So we've had some of those patients write blogs about what their condition was like, what physiotherapy, and we then put those on the website and Google finds them. And patients find that very powerful to hear what other patients have written like. But I agree
with you.
We need to the profession needs to be much more public facing about, because people don't really understand what we do. Now, what I think we will do is I would like to say a big thank you to the people who took the time to send us questions. I know we've dealt with some of them, and some of them we did do earlier on because people were asking, you know, what research you're involved in and where's the knowledge gap. So we've kind of touched on that, but we will save the rest of the questions maybe for the ultrasound one, which I think would be good to do also. I would like to say a really big thanks, Judith, for giving up some of your time. It's been really inspiring to speak to you, and I am excited about speaking to you again. And I think one good thing to come out of COVID is the ability to reach people like yourself, which I think even 3 months ago that would have been challenging. So a really big thanks. I found this a really brilliant start to my day here on Monday morning, and just say a really big thanks to you for taking the time. I really appreciate it.
And just my heart goes out to all the physios in the UK, and our thoughts are with you because we're coming out of COVID and it does happen. So it does get better, but yeah, all of you there. So best wishes to you all.
Brilliant. Thank you very much.